patients with myeloma at increased risk, that is known to everybody, for infections, bacterial infections, and particularly viral infections. And infections are the second leading cause of mortality in our patients. That is established. So we should do our utmost to prevent the occurrence of infections. And we have several measures: vaccination, antiviral prophylaxis to some extent, and antibacterial prophylaxis in special situations only, IV immunoglobulins in very special situations only, but vaccination should be offered to all our patients to reduce the risk for viral infection and bacterial infections. And so the European Myeloma Network has issued recommendations for vaccination in our patients. And of course, patients should be vaccinated against influenza. And we have to acknowledge that the immune response in patients with myeloma may be impaired, and is quite frequently impaired. So ideally, one should measure the immune response, or when it comes to influenza, just give a second shot, because with the second shot, second administration, you improve the seroconversion and seroprotection. The same applies to pneumococci. All patients should receive vaccination against pneumococcal infection. You start with vaccine, an adjuvanted vaccine against certain serotypes, and after a couple of months, 3 to 6 months, you then revaccinate your patients with another vaccine which protects against or includes 23 different serotypes. So that should be done in myeloma patients. Importantly, there is, as you know, reactivation of herpes virus infections is frequent during treatment with proteasome inhibitors, and is also more frequent when patients are exposed to long-standing treatment with monoclonal antibodies against CD38. So you should, of course, use medical prevention, namely cyclovir or valacyclovir, but you should now vaccinate your patients, and there are 2 vaccines available. The preferred vaccine is a genetically engineered vaccine, consists of the glycoprotein E of the varicella zoster virus, and that can be safely administered to the patients. And that has been shown to reduce the reactivation of herpes viruses. In addition, there are other viruses and bacteria which can be, the risk of which can be prevented by vaccination. You should vaccinate your patients against haemophilus influenza, and patients with impaired spleen function, which is quite rare, should be vaccinated against meningococci. And patients who have undergone high-dose therapy and have been transplanted should be checked for all the antibody responses to vaccines which usually are administered in childhood, which is diphtheria, pertussis, tetanus, mumps, rubella, measles, and if these are very young patients, for instance, in patients with allogeneic transplantation, you should also consider to check for papillomavirus antibodies. But nowadays, the question pops up, and that is really a very pertinent question: what to do, what to recommend patients in the COVID pandemic regarding COVID vaccines. There are now several vaccines already approved by FDA and by EMA, and more will be approved in due time. So all of those vaccines which are available now, the Pfizer-BioNTech vaccine and the Moderna vaccine, which are RNA vaccines, are very safe. The same applies to the AstraZeneca vaccine and the Janssen vaccine. So the question is, in my opinion, every patient with myeloma should be vaccinated, but with the exception of few situations. Patients with very active disease, uncontrolled disease, probably won't react, won't show a proper immune response. So it would be probably preferable to wait until the patient is until the patient's disease is better controlled and then vaccinate. After high-dose therapy, probably one should wait up to 3 months with vaccination. But if the patient is just before high-dose therapy and just collecting stem cells, I would vaccinate the patient, because there is still a good chance that he develops an immune response. And you can check the immune response afterwards, and probably also that is not standard and supported by scientific data at this point of time. It will be probably reasonable to check for humoral immune response. At least you can check for cellular immune response in your patients, and I anticipate that there will be impaired immune responses in quite a proportion of patients, and then probably one should consider vaccinating those patients. Anyhow, people with MGUS and people with smoldering should be vaccinated at any time, and myeloma patients should be vaccinated, but the response to vaccination when you have active disease, aggressive therapy, is probably very much reduced. So if you can wait and until the patient achieves a good response and vaccinate them, it's probably much better. So hopefully all our myeloma patients will be vaccinated, and because we know that myeloma patients have an increased risk for getting infected by COVID, and if they are infected by COVID, they have an increased mortality. So that is why it's an urgency to vaccinate most myeloma patients, or all myeloma patients. And actually, we did a survey about the willingness of myeloma patients to be vaccinated, and that is much higher than the readiness of the general population to get vaccinated against COVID. It's about 82%, because myeloma patients, empowered myeloma patients, know the risk of COVID and are looking for and trying to exploit all means to reduce this risk, and vaccination with COVID is certainly important in those patients.